Hi, good afternoon, everyone. Namaste. So my name is Bernie Chang, and I'm the president of the Royal College of Ophthalmologists in the UK. Thank you very much indeed for the invitation to the college to run a 1.5 hour session for you. And the title of this session is called Innovations in Education and Training. We certainly wish everybody here and their family well. It's very good to hear that the COVID infection rates have dropped in India. Now obviously, we are fully aware that the ophthalmology services in India is many times larger than we are in the UK. So in a sense, we are quite a small service compared to what you run over there. And no doubt the challenges that you face, especially due to COVID, will be bigger. And we are hopeful that we're able to give some useful tips, especially on how you can continue training and educating ophthalmologists over there. So an introduction to the speakers. So I'm a consultant oculoplastic surgeon based in Leeds, which is up in the northeast in England. I specialize in managing periocular skin cancer, thyroid eye disease, and have an interest in artificial eyes or prosthetics. And as you can see, I have done a fair amount of work for the college, but also for other external bodies. We also have Ms. Fiona Spencer, who is our chair of training at the college. And she's a consultant in Manchester Royal Eye Hospital, specializing in glaucoma, cataract, and she has a particular interest in the training and curriculum and medical leadership. She has also had various other roles, including as Associate Medical Director at her local hospital. Melanie Corbett just finished her term as our Chair of Education and Telelearning, and she's a consultant ophthalmologist in London in the Western Eye Hospital Imperial College. And she has a special interest in cornea ocular surface and anterior segment surgery, and is really, I think, a world expert on education. Our final speaker is Mr. John Ferris, who leads our surgical skills faculty at the college. And he has a special interest in surgical training, simulation, and pediatrics and squints. So in terms of the timetable today, I'm going to give a very quick overview about the impact of COVID on services in the UK and training. And this will be followed by a presentation on remote assessments and exams by Fiona Spencer, cascading training to trainers by Melanie Corbett, and remote supervision of simulated training by John Ferris. And we will have a discussion panel at the end. So please do ask any questions, which we will collect in the Q&A box. So without further ado, I'm going to start and talk about the impact of COVID on training. And the main effect it had initially was on how we provided eye care services. And obviously that has an impact on the ability we have in the UK to train. I'm going to talk about what the impact on our trainees here and what the college did in order to try to help restore services and training, and how these ideas can be taken even post-COVID. And the three presentations following mine are talking about specific innovations for training and education. So in terms of capacity, in terms of the ophthalmology workforce in the UK, you can see that we do a lot of work. We account for 10% of all outpatients in the NHS, the National Health Service, and we do 6% of all the surgeries. And this is done really by quite a small group of medically trained staff. There's only about 1,260 consultants in the UK. And therefore, we have really learned to work as part of a multidisciplinary team, working particularly with optometrists, but also with orthoptists, nurses, and technicians. So in a sense, we punch well above our weight in terms of the workforce and what we deliver. We know that from the Way Forward document that we produced, that in the next 20 years, we expect that there will be a 50% increase in demand for cataract surgery, a 44% increase in glaucoma cases, and 60% increase in the overall caseload for diabetic retinopathy and AMD. And the population is living longer. And we know that as we get older, we tend to get more than one disease. So multiple comorbidities will exist. So the complexity of the patients that we treat is also going to increase as the aging population increases. A problem that's not unique to the UK, but I'm sure is also prevalent in developing countries, is that there will be a more rapid rise in the older population in rural areas versus urban ones. This is because young people tend to move from smaller areas into big cities for jobs. And likewise, those who are retiring in the cities are more likely to move out to the rural areas for retirement. So that again increases the complexity of work in those areas. All this was before COVID hit. And when COVID hit, all routine eye care services were shut. And there was really this risk that thousands of eye patients were going to suffer from avoidable sight loss because they just were not attending even when they had urgent eye signs. They were afraid that they might catch COVID if they come into hospital, where obviously all the COVID patients were being treated. So in terms of the backlog, in 2021, we expect that there are now 5 million patients on the waiting list. This is for all of NHS, all of services, and that 4 million patients haven't even been referred yet for surgery that they probably will need. So the backlog is immense. As a college, when COVID first hit in March of last year, we set up a COVID-19 response team, and we made sure that we worked closely with NHS organizations and government representatives. We made sure that we wrote service guidance with initial focus on how to look after patients with emergency and sight-threatening conditions. So advice on how we prioritize care. And we wrote guidance on how PPE, personal protective equipment, should be worn, and how to create safe environment in clinics, from something as simple as the breast shield that we used to have for slit lamps. And then we started to write guidance on restoration of services and training and research. We really had to rethink delivery in order to reduce the need for patients to come into hospital, both because the hospitals were very busy looking after COVID patients, but also to reduce the risk of a patient coming to hospital where COVID was much more rampant. So we started to use telephone and video technology to conduct remote consultations. And we continued to prioritize in terms of risk for patients as to who needed to be seen face-to-face or who could be managed remotely. Following the first wave, we knew that we had to try to retain capacity as much as possible because the backlog was just increasing. And effective communication and early communication with your trust managers and patients was crucial. So we still continue to ensure that we prioritize and that we try to provide safe elective care sites. For example, standalone eye units were more able to continue with surgery rather than in a hospital where the eye department was part of a busy A&E or part of a busy ICU department. We definitely needed the support of our optometry colleagues who worked in the community to try to see more patients there. And we set up ways of sending data, so OCT pictures from the optometrist into hospital via something we call CUES, which is the COVID Urgent Eye Care Service Pathway. And we also started to work with local charities and eye clinic liaison officers to ensure vulnerable patients were not missed. And this really helped to reduce the do not attend, patients failing to attend our clinics. Within the hospital, we also risk assess vulnerable groups of staff For example, the ethnic minority community suffered more from COVID in hospitals, and some staff also had to shield in order to protect themselves. So beyond the first wave, we continue to develop and adopt safe and efficient pathways for working. We're definitely increasing collaboration with our MDT staff. We're setting up high volume cataract surgery and high volume diagnostic hubs out in the community so that patients can be assessed there and then remotely managed by a consultant or senior doctor in the hospital. Now, there is hope for normality in that the vaccination program has worked particularly well in the UK. Something new for our college is that we started to work more closely with the pharmaceutical industry to get sponsorship for education packages, but also for setting up community hubs. So this is just a list which you will all be provided for of the COVID guidance that we've written, and you can look at these at your leisure. In terms of our trainees, we have a 7-year ophthalmology training program, and it's usually through national recruitment that they get in, but there's also the route through what we call CSER equivalents. So those who are not in training, not consultants, might work in what we call a staff and associate specialist grade, and there is an opportunity as well for them to enter OST training, provided there are gaps in the rotation. And obviously there are different types of visas that the UK provide for overseas doctors to be able to work in the UK. And the college runs a dual sponsorship scheme for that. In terms of the staff and associate specialist grade, you can actually get equivalents to become a consultant, to be on the specialist register. This is what we call CSER. And very recently, the college was involved in creating a specialty grade. So this isn't quite a consultant grade, but it allowed for autonomous work by senior SAS doctors with the appropriate experience and qualifications. And that obviously comes with better pay. The impact of COVID on training was huge. Our trainees were redeployed because the eye department was virtually just doing emergency services. Our trainees were used to help cover wards, and some also worked in the ICU units. And quite a lot of trainees, as you can see from the initial survey that was done in May 2020, were concerned about the impact on training. And not surprisingly, the area where they were most concerned about was in the ability to learn how to do cataract surgery. And the more junior you were, the more you were worried that your chances of learning this vital skill was being delayed. In August of 2020, this picture was still very similar in that 72% of trainees felt that they were not going to be able to complete their training objectives, and 47% of them had one of their exams cancelled. In the most recent publication, and Fiona Spencer might also talk a little bit on this, our trainees still feel that they have been disadvantaged by COVID. And so quite a lot of them feel that it will impact on their future career and their ability to sit the exams so that they can progress within their training. So who's most affected? It's not surprising that the earlier trainees were more impacted. Those trainees who were less than full-time, those trainees who were shielding, and academic trainees were particularly hit. And trainees who had caring responsibilities also suffered particularly because of COVID. So what can we do? I think as trainers, we have to rethink how we supervise. We have to make most use of the opportunities we have and to utilize new ways to teach trainees, which the subsequent presentations will give you a bit more detail about. But we know that clinics are less busy. And so therefore there is an opportunity to use that time to allow your trainee to be more supervised, to give them more feedback, and to give them time to take histories from patients and for you to observe them more carefully. Likewise, in theatre, because lists were not running at full capacity, you might have the opportunity then to actually allow them to do the case because you're less stressed for time. In terms of training for future eye surgeons, we know that the NHS was very busy looking after COVID patients. So we started to work with our education bodies to see whether the independent sector, the private sector, could also offer training opportunities. And there we were very careful to make sure that the standards of training delivered by the private hospitals were at least equal, if not better, than those that they would traditionally get. So that's just a very quick overview about what happened due to COVID, the impact on service and training. And no doubt it has been very challenging and remains so, and that the balance of providing the service and training will be tested in the months to come. But we do have to be creative and use all opportunities to train and to use any appropriate setting in order to deliver training so our trainees can become good consultants eventually. So I'm now going to pass over to Fiona Spencer for the next bit.